Good evening, friends. Here we are going to discuss the role of dynamic hip screw in trochanteric fractures. In this era of PFN in trochanteric fractures, whether DHS is totally abandoned or it is still relevant for the orthopedic fraternity. Let me start with few case examples. Here is the trochanteric fracture along with the fracture shaft of femur. We fix this fracture with the long PFN, and you can see the fracture united well, and patient is fully functional. Another patient of subtrochanteric fracture with the fracture shaft of femur, that is segmental fracture. Again, we treated this with the long PFN, and you can see excellent functional outcome with the solid union. Friends, PFN is good and new arrivals are always welcome. Let it be new car, let it be new house, let it be new bride, or let it be new government and new politician. But they all need to be tested against the test of time. If we look back, see the evolution of Eliezer Rao, there was a time when each and every fracture was being fixed, tried to be fixed with the help of Eliezer Rao. Let it be mandible fracture, let it be clavicle, let it be spine fractures, even flat bone fractures. Everywhere there was boom of Eliezer Rao, but finally the gap non-union, infected non-union, and open fractures are the absolute indication for these Eliezer Rao fixators. There was a big boom for the computer navigation in arthroplasty, but you can see the conventional total knee arthroplasty is still relevant and as good as the computer navigations. You all know the fate and final outcome of metal on metal large head arthroplasty in the total hip replacement. It could not sustain even the decade. Friends, the intramedullary fixation for the trochanteric fracture is always have the mechanical advantages. Let it be Enders nail, Gross Kempf nail, Gamma nail, or even PFN. They all are the intramedullary implant and they have the mechanical advantage over the blade plate, that is extramedullary implant. But even in the intramedullary nail, which type of nail, how much should be the proximal diameter, what should be the length of nail, whether it is short nail or long nail, how many distal interlocking screws to be put, how many proximal screws, one or two, how thick should be screw, whether there should be sleeve or not. There are a lot of questions about the design of intramedullary nail. But the dynamic hip screw, DHS, the sliding blade plate, has the single design for last so many years and working with the same functional outcome of this. There is no innovation in the DHS or SHS. It means that still the nail design is not perfect. There are many studies about one or two proximal screws, and they found that there is no difference in fracture sliding or collapse. There is no difference in rigidity or stability of the construct. And exactly what is the clinical significance of one or two screws, nobody knows. They say that there should be one small screw and one larger screw, or two small screws. The ideology behind the small screw is that they protect the lateral wall. If you put single thick screw, already splintered lateral wall can be damaged more with the thick screws. The only problem with the two screws are that the small screw gets Z effect, that is Z effect, and it collapses, and one screw collapses proximally and other one penetrates the hip joint. So there is no consensus about the proximal thickness of the nail, about the number of the hip screws, about the number of the locking screws, about the direction of the locking screws. There is exactly no consensus. So they're still in the phase of evolution, while the DHS has at least decades of track record, while PFN or intermediate nail, every 5-10 years it's evolving with the nail or blade or plate or screw. It's not exactly, they have not decided how to go ahead. If we see the role of implant in trochanteric fracture management, it is only 20%. Other 80% includes bone quality, fracture geometry, quality of reduction and stability of reduction, and placement of implant, particularly into the femoral neck. So they all have the bearing on the final outcome of the treatment. Implant selection or implant role of implant is only 20%. So what this debate is about the PFN or DHS is implies only in this 20% of factors influencing the management. Friends, it is propagated that PFN is panacea. It can manage each and every fracture of the trochanteric region. Yes, it can. Even DHS can manage. But what matters is depends the fracture geometry, the reduction, the placement of implant. The implant is particular. Implant is not the panacea. You have to see the management in totality. You need the proper X-ray, AP and lateral view, external and internal rotation, and traction views. And then you see the stability of the fracture. The fracture stability relates not only to the fracture of the fragments, but the fracture plane as well, whether it is in coronal plane, whether it is sagittal plane, whether it is oblique or reverse oblique fractures, depending on their configuration and geometry. Coming to the classification, AO has very well classified these fractures. The A1 and A2 are the stable fractures. Few fractures of A2 and majority of A3 are the unstable fracture, as you can see in this diagram. If fracture is only in two parts, majority of them are stable fractures. If it is in the 3 or 4 parts, that is lesser trochanter and greater trochanter separate, it is unstable fracture. Here you can see the reverse obliquity, lot of combination. These fractures are very highly unstable. They fall into the AO 31A3 group. Coming to the bone quality, you can see the bone quality in the young age, lot of trabeculae with a good bone density. On the other hand, in the elderly patients, you can see there is a marked loss of trabeculae and there is very thin cortices and osteoporosis. You can see the implant in these patients must be placed where the remaining trabeculae reside. Coming to the fracture reduction, if we try to reduce with the close reduction in AP and lateral view, I think that is the best wire media. But if the reduction is not acceptable, even in the lateral view or AP view, we must go inside the fracture site either with the open reduction or even with the close reduction, put the Steinman pin or thick K wire and use them like a joystick and reduce the fracture in both the planes AP and lateral. And in the lateral view, see the anterior cortices. If they are at the same level, then you can proceed with the putting the implant. When you are going to put the implant, the position of implant is of paramount importance. It should be as close to as the apex of femoral head. What is the apex of femoral head? It is defined as the point where a line parallel to and in the middle of the femoral neck intersects the joint line. That is the apex of femoral head. The tip of implant should be as near as the apex of the femoral head. Here you can see in this diagram, here the apex of femoral head here and tip of the implant is there. If this distance is more, the implant is going to fail. So it should be, tip apex distance should be XAP plus X lateral. And it should be as minimum as possible. Here you can see as the tip apex distance increases, the possibility of cutout of the implant, failure of the construct increases. It is directly proportional to the TAD distance. The optimal placement of screw should be dead center and very deep into the femoral head, that up to 0.5 centimeter from the margin of the articular surface. Once you have put the proper reduction, we have achieved the stable reduction, then select the implant, whether it should be intramedullary nail or it should be blade plate fixation. What is the big deal? I think in each and every international national meeting, the PFN is the treatment of choice. That is how the things are being propagated. But the DHS, it cannot be discarded. It is not obsolete. It is still the gold standard for the stable fracture. It can be screw and plate. It can be blade and plate. It can be supported with the extension plates to address the trochanteric fractures and trochanteric problems. TSP, trochanteric stabilizing plates. If the fracture is grossly displaced, you must reduce it properly open the fracture site and then put the implant. Here in this case, you can see very good reduction in the AP view, but on the lateral view, still there is a step out there. This is not accepted. These are bound to fail, or in these cases, the sliding gate plate is going to collapse. Another few case examples being treated with the DHS, dynamic hip screws. These are all unstable fractures. You can see treated with the DHS, and this is again unstable fracture, very well fixed with the dynamic hip screw. All these fractures very well, even these subtrochanteric fractures can be very well managed with the dynamic hip screw. You can see very nice reduction with a very good fixation. So here another patient with the subtrochanteric fracture. You can see the valgus fixation with the nice bypass of the committee fracture in the subtrochanteric area. And they all united well with the few millimeter of collapse of the trochanteric fractures. So what I mean to say is that VFN is not the panacea. These all fractures are very well and can be managed with the dynamic hip screw as well. What does the literature say about PFN versus DHS debate? There are many studies by Bridle, Boriano, Lindsay, Halder, Williams, and many more. And they say that advantages of gamma clinical results are equivocal, but they have more complication rates than the DHS. They compared the gamma nail with the hip screws, the dynamic hip screws, sliding hip screws. They say that the shaft fractures in gamma 3 is more than the compressive hip screws. Required reoperations are more in the gamma nails. Intermedullary may be superior or for the inter and subtrochanteric fracture, while the CHS is a forgiving implant when used by inexperienced surgeons, but gamma nail is not forgiving. If it is not done properly, it is going to fail. That is how the M.J. Parker conclusion was in the International Orthopedics 1996. The lot of RCTs, they say that there is no difference for the stable fractures in the intramedullary hip screws or compressive hip screws and blade plate. Another clinical result of the intermedullary fixation, they say that there is less blood loss, there is improved post-op mobility, and there is improved ambulation in the intermedullary fixation, and there is less sliding, less collapse of the trochanteric fracture with the less limb length discrepancy. Reverse oblique fractures, again, the compression hip screw has more failure than the intramedullary hip screw in the subtrochanteric fractures and the reverse oblique fractures. These are the ideal indications for the PFN. Sliding hip screw is the implant of choice for the stable trochanteric fractures. The failure of dynamic screw is particularly because of the failure to achieve central placement of a screw with the excessive TAD. Tip apex distance is more, then it is bound to fail. If it is less or it is the tip of the implant is exactly over the apex of the femoral head, then it is going to have the good functional outcome and good chances of union. There are a lot of literatures which say that there is no advantage of intramedullary nail fixation over the dynamic hip screw, particularly in the stable fractures. Here in GBS 2010, you can see this prospective randomized trial that a comparison of long gamma nail with sliding hip screw for treatment of AO31A2 type of fractures in the proximal part of femur. They found that there is no difference in the reoperation, in the mobility, in the transfusions, in the hospital stay. They say that the long-term outcome of both procedures are same. But the sliding hip screw remains the gold standard. There are a lot of contraindication of intramedullary hip screws. If patient is very young, you need a lot of bone removal in the trochanteric area. So it is not indicated in the patient because they have the abductor lurch. The basal neck fractures, if you put the implant there, there is iatrogenic displacement of basal fractures. Stable fractures requiring open adduction should be fixed with the, again, sliding hip screw. And the fractures which have very narrow canal, I think in these patients, you cannot go ahead with the thick intramedullary nails. So try to treat these patients with the DHS or blade plate. There are very well-known complications. That is the downside of PFN and short nails is they give the stress risers, and these stress risers have a lot of probability of the subtrochanteric and femoral shaft fractures. You can see this the area, it is a stress riser. You can see the fracture at the tip of the PFN. Even in the long PFN, they give the stress risers, and in these elderly osteoporotic patients, you have the fracture supracondylar femur because of the stress riser at the tip of the nail. So PFN is excellent implant. It is reserved for the special situations like segmental fractures, fracture of shaft of femur along with the trochanteric fractures and fracture neck of femur. And one must use the good quality PFN. And since it is costly affair, it can be given only to the surgery of the classes, because the PFN of good quality, good company is quite costly, and it is technically demanding. It needs the expertise. Implant, as we have discussed earlier, has only the 20% deciding factor in the whole of the management of this proximal femoral fracture. You see these patients, they are not properly reduced and PFN was put. They are bound to fail because fracture geometry, fracture reduction is of paramount importance before putting the implant. You can see it is broken. Here again you can see PFN. It is failed without proper reduction, without proper coaptation of bone fragments. It is fixed and it failed. So what we wish to convey is that PFN is not panacea. It is a fracture reduction. It is a placement of implant that is going to decide how this fracture is going to behave. On the contrary, the dynamic hip screw, it cannot be ridiculed, it cannot be abandoned, it cannot be discarded. It is there to stay. This is the surgery of masses. This is technically not demanding. Majority of the fractures of proximal femur can be addressed with the DHS itself or sometimes with the trochanteric stabilizing plates along with these sliding hip screws. This procedure is time tested and it has proven results after decades. So it is associated with the similar outcome with the less expensive procedure. DHS remains gold standard and it is here to stay, and it can manage majority of the proximal femur fractures. So in conclusion, we wish to convey that DHS remains gold standard. It can be applied in the each and every fragment of fracture of trochanteric fracture of proximal femur, let it be stable or unstable. In stable fractures, I think this is the treatment of choice. In unstable fracture, you can go ahead with the PFM, which is definitely the intermediary better biomechanical implant for these comminuted unstable fractures. But even these fractures can be managed with the trochanteric stabilizing plates and good reduction at good positioning of implant. Even the DHS can be managed with these unstable fracture. So for the stable fractures, you can go DHS. For unstable fracture, PFM. But whole of the fractures are being treated with the both the ways. PFM can be done in the all these cases. DHS can be done in all the cases. But the crux of the management is there should be proper placement of implant and the perfect reduction of the fracture, make them stable. So in the end, we emphasize that this implant, which is there for so many decades, is an old implant, this is time tested, and old is always gold, and you cannot discard, you cannot abandon this procedure even in the light of PFN. PFN is better implant. It is intermediary. It has the better biomechanical advantage, but you cannot discard the DHS. Thank you.